Hello, everybody. Welcome to today's lecture entitled The Latest on Asthma Medications from SABAs, or short-acting beta-adrenergics, to biologics and beyond. I'm Dr. Albert Heuer. I am Terry Shenfield's partner and co-owner of A&T Lectures. I am also a professor at Rutgers School of Health Professions, and I co-edit 3 textbooks in respiratory care, including Egan's Fundamentals of Respiratory Care. I hope you enjoy today's lecture, and I hope you come back to us for more in your respiratory care and nursing education needs. Now, let's take a look at some of the learning objectives for today's presentation. During this presentation, we're going to focus on several specific objectives. Firstly, we'll summarize the epidemiology and pathophysiology of asthma. Now, epidemiology is a fancy word. Certainly there's epidemiologists out there that simply study disease patterns in our population. It's not really what we're going to do today. But I would be remiss if I didn't spend a few slides talking about the prevalence and the incidence of asthma in our population. It's amazing. Asthma is very widespread in our population. The scary thing is that there's probably many under or undiagnosed cases. So the numbers, the percentages of individuals in our country that have asthma may actually be understated. It's a scary thought. We'll also talk about the pathophysiology of asthma. So some of our other lectures that A&T offers on asthma cover the pathophysiology in much more detail. But again, in order to have this be a standalone presentation, I've added several slides that talk about how asthma actually occurs and what happens within the body during an asthma attack. We'll also briefly describe the evolution of asthma medications. So like I'll say in this presentation, I've been in the field about 32 years, and basically when I came into the field, it was pretty much asthmatics took their albuterol, perhaps their albuterol and Intol, perhaps their albuterol and inhaled steroid in the prescribed doses, but they took them pretty much every day. We've gotten away from that, not entirely, but we've gotten away from that. And we'll focus on how, in what manner, over what period of time, we've actually gravitated much more towards controller medications rather than beta-adrenergics or rescue medications. We'll also take a look at some recent discoveries in terms of biologics, medications that actually, if you will, interrupt the mediators at the cellular level that are implicated in causing and worsening asthmatic attacks. We'll describe the current asthma medication arsenal. We'll review the delivery systems and some of the, if you will, advantages and disadvantages of them. So we'll compare and contrast. We'll examine special considerations. For example, delivering these substances via mechanical ventilation circuits, things like continuous inhaled bronchodilator therapy, and some approaches that can be used to help minimize or prevent cross-contamination. So we're aerosolizing a medication. That's the good news. Medication is breathed into a patient who's sick. They may have asthma. They may have asthma that was triggered by an infectious process. So they're breathing them in. They're also breathing aerosol particles out, which can actually be contagious. So there's different approaches that can be used to minimize the likelihood of contaminating visitors, clinicians, and other individuals who are not, if you will, currently ill or sick. We'll review how to choose among various pharmacologic agents and delivery devices. We'll take a quick look at some likely future developments. And like I like to say, probably most importantly, I'll furnish additional resources for those of you who want to learn more about these topics. As I alluded to earlier on, asthma is a big problem in this country and abroad. There's over 25 million Americans that are diagnosed with asthma. Approximately 1 in 10 children have asthma. The annual costs are immense, 80 billion or more. There's over 3,000 deaths a year. 13, almost 14 million missed school days per year, and over 14 million missed work days per year. So you think about an individual may be themselves an asthmatic, an adult individual, and they can't go to work, or it may be a mother, a father, a guardian who's responsible for an asthmatic child who is uncontrolled. They have uncontrolled asthma, they're sick a lot, and therefore the parent needs to take off time from work, is missing work, and is missing productivity. Every day that they're not in the office, someone else needs to make up the difference, so it can be a very, very big issue. There's also significant limitations that can be placed on activity of the patient. Unfortunately, some of the actual delivery devices, most notably meter dose inhalers, but not only them, dry powdered inhalers and the like, can be misused. And well over 50%, some of the studies say over 70% of the devices are not correctly used. Sadly, about 1 in 5 individuals cannot afford the medications nor the physician or practitioner follow-up that's needed to effectively manage their condition. It's a sad reality. The definitions of asthma vary a little bit textbook to textbook, but in general, there is some nice agreement as to what constitutes asthma. So it's a clinical syndrome. Syndrome literally means a set of symptoms or clinical findings characterized by airway obstruction, which is partially or completely reversible either spontaneously or with treatment. Airway hyperresponsiveness or reactivity to various stimuli incidents. So it can be things like stress, it can be pet dander, pollen, and the like. We see the studies that actually even talk about the more discrete substances like cockroach excrement, dust, just occupational dust, certain substances that may be associated with the individual's work or occupation, farmers, things along those lines, miners who develop a sensitivity to asthma. In my particular case, I'm not an out-and-out asthmatic, but I was a swimmer in high school and college, and I developed an allergy, if you will, to chlorine of all things. So in the beginning of the swim season, I would have to take certain medications until my body, if you will, acclimatized to the exposure to chlorine. Airway inflammation is also another part of the syndrome. So where bronchial smooth muscle that actually, if you will, lines or wraps around the airways constricts, the actual cross-sectional wall of the airway becomes swollen, and there can be excessive secretions of mucus. Most recently, in 2021, there's approximately 22 to 25 million adults and about 6 million children reported to have asthma. Again, scary thing is in particular with the children, that number may actually be low, and the actual number, when you count those that are yet to be diagnosed, may be considerably higher than 6 or so million. Accounts for 2 million emergency room or ED, emergency department visits annually, and again, sadly, over 3,000 deaths per year. To illustrate what I was just talking about in the preceding slide, is you can see the normal airway on the left-hand side, the middle, the asthmatic airway, where the if you will, the cross-sectional lumen becomes swollen, becomes constricted, if you will, and then the actual wall becomes thickened. But then you have this added dimension of the bronchial smooth muscle that's tightening or constricting, and the excessive, if you will, secretion of mucus. So individuals, that's a very dangerous, at a minimum uncomfortable, but at a maximum very dangerous combination. So when you put words around the preceding slide, we talk about exacerbations, which we want to avoid. Exacerbation means a worsening, usually an abrupt worsening in the patient's condition. So we see exacerbations in patients that have congestive heart failure or CHF, patients that have COPD or chronic obstructive pulmonary disease, as well as exacerbations of patients that have asthma. And what's actually happening is you have an acute worsening of symptoms and lung function, may occur as a result of a trigger such as a viral infection, such as an allergen, simple non-management and non-compliance, pollution, irritants, and the like. The best treatment is early recognition and early interventions. RTs should be in tune to subtle changes that may provide an opportunity to intervene before the individual gets worse and requires hospitalization, misses work, affects those around them, and so on and so forth. Some of the particular risk factors when we talk about, well, what characterizes somebody who's stable, who's not so stable, and who is outright unstable? So they look at a bunch of different metrics or variables. So they basically say if in the past year the individual has had 2 hospitalizations, granted 1 hospitalization is too many, but really they're using that as a threshold to say if you've ever had 2 hospitalizations, you're not stable. 3 emergency room or ED visits, using 2, again, short-acting beta-adrenergics or SABA canisters, meter dose inhalers per month. And there's no asthma action plan. There's no plan. The individual's unstable, but there's no plan to get them stable. Previous severe exacerbation, ICU or intubation, and not adherence. So these are kind of a cluster of factors or variables that are looked at to say, is this individual stable, or are they somewhat stable, or are they completely not stable, and we need to intervene immediately. So it's easy to say exacerbations are bad. Asthmatic exacerbations are bad. They're bad for the patient. The patient doesn't feel well. They can't go to school. They can't even participate in social activities like they would. It could be sports. It could be, out with their friends, socializing, etc. So it diminishes the patient's quality of life. Elizabeth Juniper actually has asthma, has validated, meaning it measures what it's supposed to measure, and it's a survey, it's a questionnaire to actually discern or to quantify asthmatic's quality of life. Elizabeth Juniper. Okay, it's been translated into, I want to say 54 languages. It's probably more than that by now. But they can actually quantify to what extent the patient's asthma has impacted their quality of life. And it looks at many variables. Things, again, that you've heard of, we've talked about, we'll talk about a little more in this presentation, but lost school or work days, comorbidities. So you have individuals who perhaps can't participate in the sports or social activities, work even, and they can develop depression, anxiety, and other conditions as a result of that. It increases potentially avoidable, that's the key, avoidable burden on our healthcare system. Basically, a stable asthmatic versus an unstable asthmatic. The stable asthmatic, they have better quality of life, but they also place less of a burden on our healthcare system. They utilize services less, okay? They may utilize, things like preventative services, education, things along those lines, but what's not utilized are those high cost, hospitalizations, emergency room visits, things along those lines. In its worst form, an ICU visit, perhaps on a ventilator. If frequent, may result in permanent airway changes known as airway remodeling. So the body, it will kind of adapt or take on that, diminish that more, the higher resistant, more obstructed airway pattern. So it's not just this, it loses an element of reversibility, and the patient's baseline tends to diminish. So when we talk about airway remodeling, that's what we're referring to. So A&T Lectures also offers lectures, not just, this one kind of is more broad reaching, but it covers specific lectures on things like airway remodeling. On other topics we'll talk about in this presentation. But again, I talk a little bit about it here. But if you want to learn more about this and other phenomena that are discussed in the context of this lecture, feel free to again toggle through some of the offerings that A&T offers in asthma and of course in other domains. So a slightly deeper dive into airway remodeling. Many patients with intermittent symptoms have normal lung function in between, okay, in between these exacerbations. A subset, however, develops an element of irreversible airflow obstruction from airway remodeling. And again, the use of various substances decreases inflammation. The decline in lung function by reducing exacerbations, decreasing the rate ratio of death, things along those lines. So there's things that actually can be done in order to mitigate, in order to help prevent or mitigate the likelihood of airway remodeling developing. Now, the National Asthma Education Program, or NAEP, they have an expert panel. They themselves are an organization. They have a lot of really good resources, etc. But they talk about these prongs, okay, in the actual, effective management of folks that have asthma. And talk about objective measurements of monitoring lung function. Believe it or not, things like peak flow, even though peak flow is less repeatable, less reliable than some other measurements such as FEV1 or FEV1 percentage, peak flow is generally regarded as something that's easy to do. So objective measurements and monitoring of lung function is one of those prongs. The second one is pharmacologic therapy. And again, as time goes on, less emphasis on reacting in the way of promoting rescue medications such as SABAs, including albuterol. But they're still included in the arsenal. There's much more emphasis on how do we get the patient in a regimen, a pharmacologic regimen that includes controller medications that can help minimize the likelihood and the severity of asthmatic episodes. Environmental control is a third prong. So things like, if you know that, we know that individuals that live in crowded conditions in inner city that maybe move a lot, that perhaps have a insect, and particularly, insect or rodent, but particularly a cockroach infestation, where maybe it's also a higher stress environment, where there may be smoking that takes place in the premises, not just outside of the premises or beyond, or maybe in a closed car, things along those lines. So environmental control, focusing on that as well. And patient education. And that may really be patient/parent/guardian education as well. It depends on the age of the individual. They certainly should be included in the educational process, but when they're particularly young, it's really important to include others in their immediate circle as well. So in terms of what constitutes a patient who is controlled, okay, there's a little bit of variability there. But again, some of those metrics include minimal to no chronic nocturnal symptoms, infrequent exacerbations. What would that mean? An exacerbation doesn't mean hospitalization, but it means that they're actually not having to use their rescue inhaler very often. And again, some of the references will actually say if the individual has to use their rescue inhaler more than twice a week, then they're not well controlled. The exception may be for those that have exercise-induced or cold air-induced asthma. They're actually advised, where it's a known trigger, they're actually advised to pre-medicate. So they would kind of be an outlier group that wouldn't necessarily fall into, well, you're using your controller medication more than twice a week because you play soccer or you play lacrosse or whatever, football, whatever, tennis. But you do it in some cooler weather and you're exerting yourself. So there's they would pre-medicate. They may use their inhaler 5 or 7 times a week, but they're not necessarily not well controlled. Again, the minimal need for beta agonists, medications such as albuterol, no limitation to exercise activity. Again, may be advised to pre-medicate, and the peak flow or FEV1 is greater than 80% predicted, with a less than 20% nighttime variation, and minimal to no side effects for the medications themselves. The side effects can be bad in and of themselves, but the side effects can also disincent the patient to actually use the medication and be compliant with that part of the treatment plan. Again, the treatment of asthma is a little bit of a graphical depiction where you're looking at, focusing on the symptoms and the exacerbations and side effects, the confirmation of the actual, diagnosis if necessary. And again, looking at the symptoms, control modifiable risk factors, any sort of comorbidities where the individual is maybe immunosuppressed, so therefore they're getting more colds, the colds are a trigger, etc. Focusing on inhaler technique or dry powder inhaler or MDI inhaler technique and adherence, and patient and parent preferences and goals. And again, looking at the actionables, treatment of modifiable risk factors, non-pharmacological strategies, including the monitoring and education, the asthma medications, and the education and skills training, including using your DPI, using your MDI effectively. Because part of the reason for overuse is, well, they didn't get any of the medication. They put a tight lip seal, they didn't use a spacer, they put a tight lip seal around the opening of the metered-dose inhaler, they actuated it right away, and basically got a mouthful of this stuff. And none of the albuterol went to where it was supposed to go in the lungs. Under the best of circumstances, probably only about 15 to low 20s, 20, 22% actually makes it down into where it needs to go, into the middle and lower airways. Okay, it's been very well studied by Joseph Rao down at University of Georgia, his, if you will, disciple or heir apparent, Doug Gardenhire, and some of the others as well. They've really studied this stuff and to see, well, how much is the patient actually getting? Improperly used, they may be getting like next to nothing. Properly used, they're getting an appropriate dose. And these medications are dosed with the anticipation that the patient is only getting, 15 to 25%, something along those lines. So those doses anticipate the patient's not getting 100% of the medication. So let's look at some of the milestones in the, if you will, development of the asthma medication arsenal. So in the 1950s and 60s, you had these, catecholamine, adrenergic bronchodilators, very short-acting, many side effects. Again, not necessarily life-threatening side effects, but things like tremors and tachycardia. So some of the medications that were out there and actually still are, sub-Q epinephrine. When I first came into the field, again, 30 plus years ago, actually, when we took the clinical simulation, it was still one of the recommended treatments for someone in a severe exacerbation. Things like epinephrine. So by the way, Primatene Mist, and it's still on the market today, is epinephrine. So it's still on the market today. It's still over the counter today, oddly enough. It's epinephrine. So think about it. It's just strange because, epinephrine, including racemic epinephrine, it does have a bronchodilatory, effect to it, but it also can do things like vasoconstriction through alpha receptor stimulation and beta-1, which can impact heart rate by increasing the heart rate. Alupent being another one of the medications, isoproterenol, another one. I could go on and on, but you get the idea. So they were medications that, could be effective and very quick acting, relatively short acting, but quick acting, but also had a lot of other side effects that could be bad in and of themselves, but it could be bad because the patient doesn't want a fast heart rate, doesn't want to feel jittery, so they don't use their medication, so they're not compliant. So hence in the 70s and 80s and early 90s, these non-catecholamine adrenergic bronchodilators are introduced. Albuterol. So albuterol was introduced some 40 years ago, is still kind of a mainstay, a short-acting beta-adrenergic, but we're in the context of a PRN medication. If the patient needs to use it all the time, unless they're in that subgrouping of cold air exposed and athletic, particularly those where it's both cold air and athletics, they may be using their albuterol as a quasi-prophylactic medication. But you also had other medications that were gaining a foothold, including inhaled steroids and even medications like mast cell stabilizers, such as cromolyn sodium. And we'll talk briefly about that classification as well as we proceed through this presentation. More in terms of the milestones. In the late 90s, early 2000s, much larger emphasis on asthmatic education. So the other prongs in the asthma management strategy or approach, more on prevention. The leukotriene inhibitors, including single air, but not only. The Xopenex or levalbuterol that was, I want to say alleged. So levalbuterol and albuterol pretty much have the same efficacy on enhancing FEV1 and peak flow. And there is some data out there to suggest that Xopenex or levalbuterol may offer fewer side effects. So there is some truth to that. Xopenex is now actually available in its generic form, but for a long time, Xopenex was a lot more expensive, like 7, 8, 9, 10 times more expensive than albuterol. So it really kind of fell out of favor. And it was taken off a formulary. In many hospitals, it was taken off and never added back, even when the generic was available. But in any event, other adrenergics were, basically the beta-adrenergics were de-emphasized. Again, greater than 2 times a week. Generally was equated to being an unstable asthmatic. 2010, the fluorocarbon-based propellants were phased out in favor of the HFA, propellants. And that really, that drove some of the HFA, basically took these albuterol MDIs that were as cheap as $10 or $20, it drove up the cost. It also resulted, or was one of the bigger drivers in the rapid expansion of dry powder and inhaler use. And 2010, also 2020s, explosion in the combination of dry powder and inhalers, both singular but also the combos. And we'll talk about some of the combos. There's a plethora of them out there. So I didn't make, talking about each one individually the focus of the presentation. We do talk about some of them because that could be a presentation in and of itself. And anybody who's still working, whether you work in acute care or non-acute care, even home care, you're encountering a lot of patients that are on one or more of these combo DPI or dry powder inhalers. It's also, if you will, lighten the load for inpatient individuals as well. So for us, I still work at the bedside 1 or 2 days a week, and I'm with students in clinical, so I'm with them there. But I also work as a respiratory therapist, mainly in step down and adult ICU. But these dry powder inhalers have really eased the burden on floor care. So we try to get patients converted to dry powder inhalers as soon as we practically can. And that's a good thing because they're just, a lot of times they're 1 time a day, at most 2 times a day. And it eases that burden of floor care. So explosion in combination TPIs, and then the biologics, which I'm going to talk about later in this presentation as well. They're a potential game changer, not for every asthmatic, but for perhaps a significant percentage of them. So some of the following slides I'll go through rather quickly. It's not to be dismissive, and it's not to make it like I'm racing through these, but when I talk about adrenergic bronchodilators, you guys, when I say you use them, you administer them routinely. Again, irrespective. If you're in a skilled nursing facility, if you're in acute care, if you're in home care, maybe you're not administering them in home care, but you're certainly helping set up the equipment, helping doing some of the education, monitoring, and that sort of thing. So adrenergic bronchodilators indications, short acting, so the rescue medications for relief of acute reversible airflow. Longer acting ones, we'll talk briefly about them as well, for the maintenance. So salmeterol would be a longer acting versus albuterol, which would be a shorter acting. Racemic epinephrine, I included it in this category. Again, it's more for our airway inflammation, upper airway inflammation, to reduce the swelling, but it does have bronchodilatory effects, and I would be remiss were I not to include it in this slide. A little bit on the mechanism of action. So the alpha receptors, cause vasoconstriction and vasopressor effect. Beta-1 is, basically has to do with heart rate. Beta-2 is what we want. We want these drugs to be beta-2 specific as much as possible. That's going to achieve, the bronchial smooth muscle dilatation. Also can have a little bit of effect on decreasing things like, if you will, the secretion of mucus, and can also enhance the effectiveness of some of the other medications we're giving, such as inhaled steroids. Breaking the adrenergics down into 3 main subgroups. So ultra short acting racemic epinephrine, it does lack the beta-2 specificity, does have those cardiac side effects, strong alpha-1, and is metabolized rapidly by a COMT, which again is an enzyme produced in the body. Short acting, so this is an ultra short and this short acting, so your albuterol and your levalbuterol, they tend to be pretty beta-2 specific. Duration of action approximately 4 to 6 hours, and they are suited for maintenance therapy, but not maintenance whether you need it or not. Maintenance in terms of where you have breakthrough episodes. Longer acting, so salmeterol being one of them, formoterol, and aformoterol is another one as well. And these are longer acting. Duration of action is about 12 hours. Therefore, they're often BID or twice a day. The mechanisms allow for persistent receptor stimulation over a prolonged period of time. And then you actually have some of these ultra long acting medications that are out there. Vilanterol is an ultra long acting available in combinations as well. So ultra long acting can be even up to a once a day administration. These drugs, meaning adrenergic bronchodilators, tend to be fairly safe. It doesn't mean they don't have side effects, but in comparison to some other medications like cancer therapeutic medications, some cardiac medications like digoxin and other sorts of medications, these drugs are pretty safe, but they still have side effects. And some of the more common ones are tremor, headache, insomnia, and nervousness, particularly for the last two for individuals that are taking their inhaler 15 minutes before they go to bed. And that's not well advised. A few hours before they go to bed, because a lot of times these side effects, we are actually doing, stimulating the fight or flight. So you get a little tremors, the heart rate goes up, they tend to be transient. So they tend to dissipate. Whereas the bronchodilatory effects will last 4 to 6 hours. Those untoward side effects will be, 15 minutes, 30 minutes, an hour, rarely much more than that. The adverse effects of potential dizziness, hypokalemia, so a decrease in serum potassium, which is generally not a big issue unless the individual is already starting off either with low serum potassium or they're borderline, where their serum K is 3.5. That's the low end of normal, and maybe giving them treatments times 3 in the ED brings them below that. P.S. This is a sidebar, that continuous if you will, albuterol inhalation therapy is also a bridge treatment for hyperkalemia. So you're not curing the problem, the electrolyte disturbance causing the hyperkalemia, but it is until they figure it out. There's cases where the individual is given either treatments times 3 or they're given continuous therapy until they can fix the underlying issue. Nausea, tolerance of tachyphylaxis, where the patient uses it or overuses it and they have less of a positive effect. Worsening of VQ ratio, so you have an individual who maybe they have an obstructive disorder, they have an acute obstructive disorder, the body will actually, if you will, constrict the vessels serving those portions of the lungs that are not well ventilated, and all of a sudden they're well ventilated. So now you go from having a low to moderate V, low to moderate Q, to having a pretty good V, but the Q kind of lags behind. So that can be occasionally, very occasionally, an issue as well. Just to take an example, common dosing and frequency for albuterol, 2.5 milligrams, 3 mLs, about every 4 to 6 hours. The assessment of the bronchodilator therapy based on indications for the aerosol agent, vital signs, breath sounds, looking at the patient. Do you feel better? Asking them subjective things as well. Listening to them. The thing is, sometimes the patient is really diminished. You give them treatments times 3 and now they're wheezing. That can actually be a positive finding. If they look better, but they're wheezing more and they feel better and the respiratory rate has come down, perhaps it's actually working. And what was happening with those diminished breath sounds is you have to have some decent air movement to wheeze. So maybe they were really clamped down and now they're opening up. So if they're wheezing more, but they're looking better and they're claiming to feel better, that may be a positive finding. So again, we never use one clinical finding to make it, to help, assess whether something's working or their need for therapy or their need to alter or start or discontinue a therapy. We look at a montage of things, including how the patient feels, how they look to us, and then the more objective measures such as heart rate, respiratory rate, etc. Patient subjective response, again, is really critical. Now let's transition over to the anticholinergic bronchodilators. It's a pretty rich slide here, but I'll go through it pretty quickly. Second line category for a bronchodilator for asthma. So it's really these anticholinergics such as Atrovent are really more for COPD. It doesn't mean they don't have a role in asthma, but just to be clear. So the anticholinergics tend to have a slower onset but a longer duration. Cholinergic blocking agent is effective only if bronchoconstriction exists due to cholinergic activity, which is less common in asthma. as I said, it is a first-line treatment, or this classification of meds, or first-line treatment in COPD. Maintenance treatment in COPD combined with beta agonist is indicated for use in COPD patients receiving regular treatments who require additional intervention, additional bronchodilation for the relief of airway obstruction. The example, again, ipratropium bromide, tiotropium bromide, some of the others are listed here as well. And just looking at things like atropine or ipratropium bromide, 0.5 milligrams in 2.5 to 3 mLs about every 6 to 8 hours. And then you have your combinations of your duonebs, et cetera, that combine adrenergics like albuterol with anticholinergics. Another classification of medications or inhaled medications that have been around for, since I've been in the profession are inhaled corticosteroids. These indications orally inhaled preparations used for anti-inflammatory maintenance therapy of persistent asthma and severe COPD. The use of intranasal steroids is control for allergic and non-allergic rhinitis. So runny nose, if you will, postnasal drip. Mechanism of action, the lipid-soluble drugs that act on intercellular receptors. Full anti-inflammatory effects require often a minimum of a few hours, of 4 to 6 hours, but they can achieve more of a desired effect in days. Will not provide immediate relief for if the patient has an acute asthma attack. However, if a patient in an acute asthmatic attack presents to the ED or ER, they will receive, adrenergic bronchodilators, but they're probably also going to get IV steroids right away, with the idea that hopefully in 3, 4, 5, 6 hours that those steroids will really start to kick in and the patient will feel some relief. Some of the adverse effects, so systemic versus inhaled. Systemic, so you can have adrenal insufficiency, extrapulmonary allergy, acute asthma. Basically you'll have suppression, of your cortisol, your natural cortisol secretion, which happens very, very quickly, by the way. And it can be, if you will, minimal to very significant, and it's dose dependent. Growth retardation, osteoporosis, others like prone to infection, so a diminishment of the of the patient's immune system, Cushnioid syndrome, which is a concentration or a heightened concentration of fat, and then you also you have the less but notable side effects of inhaled, or if you will, local/topical steroids. Oral fungal infections, dysphonia, that's, speaking, if you will, in a coarse manner, cough, bronchoconstriction, incorrect use of MDI can be an issue as well. So incorrect use of MDI is kind of a standalone there, but it will probably result in either none of the med getting administered, or it getting administered, but getting administered to the mouth and the throat rather than into the lungs and the airways. And that just doesn't just leave the patient exposed to a lack of the effect of reducing inflammation, but also of the candidiasis, if you will, fungal infection of the mouth and the throat. So inappropriate use can result in more deposition through inertial impaction in the mouth. Not a good thing. Looking at the inhaled corticosteroids, as far as the assessment, did they work? There are use strategies for the assessment of similar to those used for the evaluation of bronchodilators. In addition, make sure the patient understands the importance of consistent use and not to use it as a rescue drug. To instruct the patient to use in terms of a peak flow meter. To assess the patient for side effects, including, helping prevent the side effects through a mouth rinse after they actually use their inhaled steroids to help reduce the chance of candidiasis. So at the risk of not just reading a slide to you, I've just included some of the major, if you will, inhaled steroids, that some of which, beclomethasone, the first one there, has been on the market for, I want to say, forever. But some of these others are newer. Certainly Flovent is not new, but it did follow probably a decade or so after beclomethasone, and some of the others that are, listed in here as well. But there's different, formulations as well. And certainly these inhaled steroids are also used in these combo, mainly dry powdered inhalers, but some of the others as well. And we'll talk about those more as we proceed through this presentation. The combinations is where there's been an explosion. I don't mean that in a bad way, but there's been an explosion in the development and the release of certain combo medications, whether they be meter dose inhalers, but more commonly dry powdered inhalers. So you have the Advair Discus. P.S. The Advair Discus now has many competing combo medications, because for a while Advair was that the Department of Health and Human Services, Medicare Part D, was spending the second most of any drug administered to Medicare beneficiaries for Advair. So we've since seen it's still on the market, still used, still a great drug combination. The price of it has come down, but now you have a lot of competing medications that are showing approximately the same efficacy, in a few cases better. And then I've just gone down, looking at things like Symbicort, which is it's not a dry powder inhaler, it is a meter dose inhaler, and others that are listed down here. Brio, if you watch TV, you even see, Trelegy for COPD. So I realize this is an asthma presentation, but also to kind of give you an idea, some of these medications can also be effective in helping control asthma as well. So there is this crossover. It's not that, ipratropium is used exclusively for COPDers and never for asthmatics, and, albuterol for asthmatics and never COPDers. It's not the case. There's clearly a crossover effect. Plus, inhaled steroids are clearly used either alone or in combination for both asthma and COPD. Now, focusing beyond the more traditional bronchodilators, inhaled steroids, we have other classifications of medications that are used as controllers. Okay, so we talked about the steroids. I mentioned Intol or chromium sodium in the very beginning of the presentation, but it's only one of several controllers. So let's take a look at these. So of course we have Intol or chromium sodium. That's one of them. But we also have these anti-leukotrienes or leukotriene inhibitors. So to be clear, that when an individual has an exposure to a stimuli they're sensitive to, okay, who has asthma, let's say, and let's just keep it simple, say it's pollen. You have a cascading effect. The body recognizes the pollen. It usually happens pretty quickly, or very quickly, and there's substances that are released, including histamine, including leukotrienes. And downstream leukotrienes, and I'm saying it in the slide, will cause bronchoconstriction, mucus secretion, vascular leakiness or permeability, and then this plasma exudation, this leakiness into the airways. And these classifications of drugs will inhibit this effect. We also have, and I spend several slides, not at the end, but near the end of this presentation, talking about a brand new, I say that with kind of tongue in cheek, Xolair has been out for a while, going on a decade, but they're gaining popularity, they being monoclonal antibodies, okay? Again, discussed in some detail later in this presentation. And then again, the ensemble of CEU educational offerings that A&T puts forth on asthma includes, again, many different presentations that take a deep dive into these. And one of them in particular takes a deep dive by our colleague Kenny Miller, takes a deep dive into these monoclonal antibodies, also known as biologics. I'll take not a shallow dive, I'll take a medium dive into these biologics to just increase your familiarity. P.S. I myself am learning more and more about these medications as well. I'm intrigued, absolutely intrigued. I talked to some of my pulmonologist colleagues, and they're learning as we speak as well. So we're kind of educating ourselves. But they're actually starting some patients on these medications and observing the effects anecdotally, and they're also reading the research on them. So I don't want to tip my hand any more than I just did, but we'll talk more about them, these biologics, further in the presentation. Indications for use of non-steroidal anti-asthmatic drugs, prophylactic, the management of persistent asthma. They offer no benefit if the patient is actually in an acute, asthmatic attack or an obstructive, crisis. Chromium sodium and anti-leukotrienes may be used as an alternative to steroids in patients with persistent asthma symptoms that don't respond well to the steroids. And again, the monoclonal antibodies are available, but I want to stress that at this time they're available where it's suspected or confirmed that a very specific set of circumstances, or if you will, a chain reaction within the body is implicated. So they don't work in everybody, but they work in certain patients that have, eosinophilia, or they have a demonstrable measured increase in certain types of antibodies that can be better controlled with these monoclonal antibodies. And these drugs universally end in MAB, okay, and there's other MAB, so that stands for monoclonal antibody at the end, and at the end of the name of the drug. So any drug you see that ends in MAB, it's a monoclonal antibody. And these exist not just for asthma, but for some of those plaque psoriasis and some of the conditions and medications that you see advertised on TV. The good news is we have these alternatives to inhaled steroids as controller. The bad news, and it's not horrible news, but the bad news is, of course, they have their adverse effects. In the case of these leukotriene inhibitors or anti-leukotriene agents, headache, dyspepsia, it's an upset stomach, liver enzyme elevation, that's not innocuous, particularly if you have a person who's already on medications that can be hepatotoxic, or they drink alcohol a lot, or they take other, if you will, recreational drugs, things along those lines. It can become an issue, something to be aware of. As far as the monoclonal antibodies, there's less known about them in general, but also in terms of adverse effects. They can have injection site reactions. So a lot of these medications are taken, there's like a subcutaneous injection. So it's not injected directly into the muscle or the fat, but it's a subcutaneous. So that you can have injection site reactions, viral infections, headache, sinusitis, and pharyngitis. Like it's kind of this raspy throat, sinusitis, the inflammation of the sinuses, etc. Nothing life-threatening, but something just to be aware of. So as far as the pressurized meter dose inhalers, the technique for use, most patients do not use proper technique. Thorough education can take up to 30 minutes, but let's even say it's 10 minutes. The meter dose inhaler should be actuated at the beginning of inspiration with the mouthpiece held about 4 centimeters from the open mouth. So roughly 2 fingers away from the open mouth. The technique for, the MDI, concerns with open mouth technique, again, ipratropium bromide can be administered or can be sprayed inadvertently into the eye. And that's not a big deal for a lot of individuals, although it may be uncomfortable. But for individuals that have narrow angle glaucoma, it can be a very, very big deal. So it's something to keep in mind, because what it can actually happen is it can increase interocular pressure. So anticholinergic medications can result in the retention of fluid, retention of urine, retention of ocular fluid, and can increase that pressure and can worsen the condition. Okay, so again, if there's not the presence or suspicion of wide angle glaucoma, not a big deal. If there is, it can absolutely be a big deal. And then the issue with steroids, that if you have a lot of the medication that ends up in the mouth and the throat, then you have a higher incidence of candidiasis infection of the mouth and the throat, which can be uncomfortable and require things like a nystatin swish or wash for a period of time. But it can also, the discomfort can also disincent the individual to be compliant with the actual medication regimen. Different strategies can be used to enhance drug delivery. Basic concepts for spacer devices include small volume adapters, open tube designs, where you actually have a 50 ml section of aerosol tubing at the end. So it acts as a reservoir. They'll get more of the medication because they'll rebreathe some of that medication, but also will keep that medication away from the face and the eyes. In the rare instance, the individual has narrow angle glaucoma or some other condition. Bag reservoirs, I'll talk a little bit about them later in the presentation, and valve holding chambers, and I'll show you some of those in a few slides. All spacers and distance between MDIs and mouth, reducing the initial forward velocity of the MDI droplets, which, by the way, is a good thing. So if an individual, all else constant, takes the MDI doesn't, now it's recommended that the spacer be in the mouth as they actuate it, but if they didn't actuated it, waited 3 to 5 seconds, those aerosol droplets, the moisture in them will evaporate and you'll achieve a smaller particle size. So actuating and waiting a brief period of a few seconds can actually enhance, if you will, deposition to where you want it from. So it can reduce this oral pharyngeal deposition, and you can imagine in steroids, that's a good thing, but it's also you're getting more of the medication where you're intending to. The holding chambers incorporate one or more valves that prevent aerosol in the chamber from being cleared on exhalation. Provide less oral pharyngeal deposition, higher incidence of respirable, breathable drug doses, and better protection from poor hand-breath coordination than simple spacers. So understand, they're similar. The spacers and the holding chambers are similar. They're not exactly the same thing. So that subtle difference that I've made here. And just showing you some examples here of some of the holding chambers. Obviously the size of the masks are varying here. On the left-hand side, that was small one that you'd administer to, very young patients. The yellow one, the pediatric patients, and then your one all the way there on the right-hand side to either older pediatric patients or adults. So this is just to show you that the evidence. There's information and studies that are written that really talk to the issue of treatment troubles as far as a technique. So improper inhaler technique is associated with poor asthma control and frequent emergency department visits. I'm not going to read this entire slide to you, but I actually have the authors are listed here. So you can look this up. In the bottom, I actually have the citation, but they really talk about the study features. Look at about 450 patients. They give you the split between male and female, but the results. So let's look at the results. Improper use of asthma inhaler devices was observed in about 45% of the cases. So before I mentioned 70, okay, I wasn't lying to you, but this particular study is pointing to almost 50%. Less than that, the number I cited before, but still a hugely significant amount. And the improper use was associated with irregular clinic follow-ups, lack of asthma education, uncontrolled asthma, the scores that are associated, the severity scores, 3 or more ED visits, and duration of asthma of less than 52 weeks. So all of these factors are extremely important and implicated in whether the patient uses the device appropriately, which is a good thing, or whether or not they do not. Traditional or pneumatic small volume nebulizers have been the mainstay in aerosolized bronchodilator and other respiratory medication administration. So most of them are powered by high pressure oxygen or air. However, there's for home use and, if you will, certain skilled nursing facilities and other subacute facilities who don't necessarily have piped in compressed air or oxygen. They can use these compressors that put out 20 to 25 psi. They're more than adequate to drive the small volume or pneumatic nebulizers as well. So they're still commonly used. The factors that affect nebulizer performance include the design, the actual flow. So for certain devices, including one I'll talk about later on in this presentation called the circular pneumatic nebulizer, it's really designed to minimize the dispersion of aerosol particles. The manufacturer explicitly specifies that the flow be 7 liters per minute for that particular device. Often it's a range. So often it's 5 to 10, 5 to 8, something along those lines. The gas source itself, so we want to try to maintain the patient's FiO2. If they're on room air, then we can, chances are, very safely give them the treatment with air. If they're on oxygen, depending upon the percentage of oxygen, we can adjust accordingly in order to maintain the FiO2. If they're on high levels of oxygen, such as a high flow nasal cannula, then we need to really be thinking about a different device altogether, such as a vibrating mesh aerogen or similar nebulizer. The density, the humidity, and the temperature also affect and the characteristics of the drug formulation. For example, if you're giving hypertonic saline, particularly 7% saline, that over time, over multiple doses, can leave a residue, a salt residue, which can affect the functioning to a lesser extent of small volume nebulizers, to a greater extent, it can affect things like ultrasonic and vibrating mesh nebulizers. So there's different variants of small volume nebulizers. So in general, there can be the type where it's continuous, but it has a simple reservoir. So for instance, you put a 50 ml piece of corrugated or aerosol tubing on the exhalation side of things. Again, that will, as I said earlier, will minimize the exposure to the face, unintended eyes, things along those lines. But it will also allow rebreathing of the medication and can increase the inhaled dose, considerably. So something to keep in mind. Continuous nebulization with a collection reservoir bag, so using a bag instead of the actual the piece of tubing itself. Again, later in this presentation, when I talk about the circular nebulizer, I will actually show you what that actually looks like. The breath enhanced, so generate aerosol continuously using a system of vents and one-way valves. And then the breath actuated can increase inhaled aerosol mass by 3-4-fold over conventional aerosolization. So it's only aerosolizing when the patient is actually breathing in, and it's not wasting all that aerosolized medication in between breaths. Much more efficient way of administering. This is a little bit more detail on the breath actuated small volume nebulizer with a little bit more elaboration on how it works. Air from the compressor breaks the liquid medication into smaller breathable particles, which is the whole basis of atomizers. But when they have a baffle, it becomes a nebulizer. So it's to actually reduce the size of those particles. As the patient breathes in, the valve at the top opens, letting air in, speeding up the mist generation. When the patient breathes out or exhales, the top valve closes. So it actually slows that, and it reduces the amount of, if you will, wasted dose. Regarding the actual technique for small volume nebulizers, so slow inspiratory flow optimizes the aerosol deposition. Selection of delivery method, mask or mouthpiece, is based on patient ability, preference, comfort, with that one caveat that if the patient has a condition like narrow angle glaucoma, you really should steer clear of a mask and deliver it with a mouthpiece, particularly with medications like ipratropium bromide / Atrovent. Infection control issues, nebulizers should be clean, disinfected. So we're really talking about infection control to the patient themselves. Then there is the issue on top of this of cross-contamination to folks like us who are actually administering these medications to our patients. And we'll talk a little bit more about that, how to minimize the cross-contamination and techniques for doing so. Now we're shifting over to dry powdered inhalers. They've been around for a very, very long time, but their use has exploded. The variety of medication and medication combinations that are available via dry powdered inhalers has exploded. So these breath actuated dosing systems, patient creates aerosol by drawing air through the dose finely milled drug powder. And the dispersion of powder into respirable or breathable particles depends on the creation of a turbulent flow in the inhaler. Flow is a function of the ability of the patient to inhale powder with sufficiently high inspiratory flow rates. Do not use propellants, so they don't use propellants, and do not require a hand-breath coordination needed for DPIs. So some of the cost issues that you see with the newer propellants, and certainly the prior issues with the potential for eroding the ozone, those issues go away when you're using dry powdered inhalers. Here again, there's different categories of dry powder inhalers. There's the unit dose DPIs. So the aerosolizer and the hand inhaler dispense individual doses of the drug from a punctured gelatin capsule. So that's one type. You're actually loading it with each individual administration. The multiple unit dose DPI, so like a disc inhaler, these are becoming increasingly popular where you're not having to load, and it will tell you the remaining number of doses that are there. So a disc inhaler contains a case of 4 to 8 individual blister packs of medication on the disc inserted into the inhaler. And then there's the multiple dose drug reservoir DPI. Twist inhaler, flexi inhaler, discus, Advair discus, are preloaded with a quantity of pure drug sufficient for dispensing up to 120 doses of the medication. It's important to keep in mind that dry powder inhalers have factors that affect the performance and the drug delivery. They include intrinsic resistance and inspiratory flow rate. In fact, in order for an individual to effectively use a dry powder inhaler, they need to be able to generate a sufficient inspiratory flow. Exposure to humidity and moisture can render them useless or can diminish their ability to, if you will, result in dose being administered to the desired area. Patient's inspiratory flow ability, and then the actual technique. Patients, again, must be able to generate sufficient inspiratory flow of a minimum of 40, but they say at least 40 to 60 liters per minute to produce the breathable powder aerosol. DPI should not be used by infants if they can't really follow commands, etc., small children, those who cannot follow directions, and patients with severe airway obstruction. Severe airway obstruction. Think about what's going on. You have trouble breathing in to start with, so the last thing you want to do is actually give the patients a device that's really not going to, it's either worsen their condition or they're not going to be able to get the drug to where it needs to go. For a long time, there was a black box warning on Ceravent, salmeterol. And salmeterol alone was in kind of a gray, kind of putty colored discus. And what was happening was individuals who were in a severe asthmatic episode were reaching for their Ceravent, and they weren't getting relief. In some cases, it was horrible results where these patients, a few patients actually died, but a lot of them were just, had to be hospitalized. It was a very bleak, with bleak results. And some of that was the result of, or supposed the result of the fact that the drug, salmeterol, is a long-acting. Okay, so it's not going to act immediately. It's long-acting, but it's not going to kick in very quickly. The other part of it was the actual administration of the medication through the discaler, the dry powder inhaler, and patients that were in the severe asthmatic episode were not getting the drug. They were not getting enough of the drug that was a long-acting, not immediate-acting drug. So it was kind of a combination. Since then, approximately, and I'm pausing as I'm saying, it's approximately a year and a half, more than a year ago, the black box warning was actually dropped with Ceravent, but it was on for a very, very long time. I'm going to guess it was around a decade, something along those lines. Again, a little bit more, DPI should not be used by infants, as I said, requires cleaning in accordance with the product label. So making sure that, the patient isn't putting their lips on a device that's been contaminated and they're infecting themselves or inoculating themselves. And this is a summary slide that I actually put together. It doesn't have all of the major advantages and disadvantages, but it has the primary ones of these delivery systems. So the meter dose inhaler is convenient and portable. That's the advantage. Disadvantage is it requires coordination and there's a high percentage of oral deposition. There's others. There's other advantages and other disadvantages as well, but those are the major ones. The MDI with spacer, less coordination is required, no drug preparation, and less oral deposition if it's used with a spacer or a holding chamber. However, they're less portable. There are some collapsible, if you will, holding chambers or spacers that are out there. More complex than an MDI. Not terribly complex, but more complex. Dry powder inhaler is certainly convenient and portable on the plus side. On the negative side, high inspiratory flow needed, risk of oral deposition can be issues. Small volume nebulizer, inexpensive, kind of tried and true, less coordination needed. However, the device and the drug prep is needed, so you need to put the solution in the nebulizer, connect everything appropriately. Longer treatment time, particularly if it's that home compressor, could take up to 15 minutes for, let's say, a duoneb medication, and then if you throw some budesonide in there, a steroid, it could be 20-25 minutes. Vibrating mesh, I threw that in there. We really haven't talked much about them, but they're quiet, small residual volume. Residual volume is the amount of drug that's left in the nebulizer that can't be nebulized. Okay, so there's a small amount of residual or dead volume. With some forms of small volume nebulizers, you have more. However, they're expensive. A power source is needed, and sometimes, frankly, they don't work properly. As I mentioned earlier, if you're administering a drug like for a patient who has retained secretion, such as 3 or 7% saline or hypertonic, those vibrating mesh, the mesh itself can become, if you will, caked up with the salt crystals and render them non-functional. Now, there's a host of, if you will, algorithms and protocols that are out there on, selecting the particular device. This is just one of them. I deliberately selected one that's relatively straightforward, but there's others that can get more discrete and complex. So basically it starts with, up in the upper left, the kind of long rectangular box, need established for the aerosol drug therapy. And what would go along with that is either they've qualified per a protocol, or you've gotten a prescribing clinician, a physician, MP or PA's order to actually administer the drug. The drug formulation dictates delivery of device. Does it, is it only available in a DPI, for example? Use the required delivery device. Is a patient acutely ill? If it's yes, the small child. So you get the idea. I'm not going to walk through all of this, but when you see an algorithm, by the way, when you see those diamond shapes, those are decisions. Okay, so the shape of the of the step in the algorithm, it matters. In this particular case, the diamond shape is a decision. Are they ill, yes or no? So it's dichotomous. If it's yes, you go one direction. If it's no, you go the other. So a lot of this is kind of intuitive, but they're out there as a guidance, for maybe your new graduates, for maybe your travelers who, traveling staff or agency staff, or again, your new hires who are less familiar with, the protocols that you have in your place. Good idea to put these algos together, and this is just one example, relatively simplified one. So in accordance with our special considerations as one of our objectives, so we talk about these special considerations. We have a few categories. Again, I could go on and on about it, but let's focus on some age-specific ones. So infants and children, smaller airway diameter than adults, that speaks for itself. Breathing rate is faster. Particularly infants tend to be obligate nose breathers, okay? So they can filter out large particles. Lower minute volumes, devices requiring cooperation should be avoided, as I said earlier, and patient cooperation ability varies with age and developmental ability. There's different studies that look at crying. Crying can reduce lower airway deposition. However, it's been speculated that depending upon how it's actually done, that's debatable. They say actually crying can result in deeper breathing. Blow-by should be avoided. So, in the main, in general, okay, you can use meter dose inhalers, but in general, if you're using a small volume nebulizer, you use a mask. It doesn't have to be strapped on the patient, but it should be kept, by their face. This is where the parent, if it's a very small child or an infant, can be very helpful. Again, blow-by, it's been studied, and really they find that the patient gets very, very little, if any, of the medication. So it's not recommended any longer. Now let's take a look at continuous nebulization. So again, in general, for refractory bronchospasm or status asthmaticus, so continuous bronchodilator therapy with nebulized aerosol doses ranging from 5 to 20 milligrams per hour have proven to be safe for adults and pediatric patients with severe asthma. Okay, so in general, that's really the dose that you're looking at. Patients should carefully be assessed every 30 minutes for the first 2 hours, and this is general guidance, and then at least hourly. Patients must be observed for adverse drug responses. Things like positive response indicated by an increase in peak flow rates after, about 10% after the first hour therapy. The goal is obviously significant increases as well. Keep in mind that continuous albuterol, as I mentioned earlier, can also be administered to patients for severe hyperkalemia. So again, you're not solving the underlying electrolyte disorder, but you are, if you will, treating a manifestation. And as we know, hyper or hypokalemia can have pretty deleterious effects. It can certainly be the out-and-out cause of certain dysrhythmias. It can cause muscle weakness. Can cause other disturbances. Can actually cause further downstream, if you will, electrolyte disturbances as well. Now let's take a look at some special considerations relating to mechanically ventilated patients. So first of all, the placement of the aerosol generator in the ventilator circuit can have a substantial impact on the amount of drug that's actually delivered to the lungs, the available lung dose of the drug. During adult ventilation, without a bias flow in the ventilator circuit, if you're using an aerogen, so a vibrating mesh, should be placed on the dry side of the humidifier. The dry side is between the ventilator and the humidifier, not between the humidifier and the patient. The next slide will actually show you an image of what this looks like. Small volume nebulizers should be placed 18 to 24 inches from the patient in the inspiratory limb. When I say obviously using a spring-loaded T-piece so that when it is not in place, you're not losing any volume. When it's in place, it's actually delivering medication to the patient. In contrast to these other delivery methods, MDIs are more efficient when placed close to the patient. So essentially at the circuit, or if you will, the patient Y, the Y in the circuit. And many conventional ventilator circuits will actually have if you will, an adapter in place, or there's many commercially available adapters that can be placed in the circuit to actually activate the meter dose inhaler. Now with MDIs, it is often, if for instance a spontaneously breathing patient is taking, 2 to 3 puffs every, 4 to 6 hours. Often when these medications, beta-adrenergics and others, are administered via an MDI in the ventilator circuit, that dose is increased significantly with the mindset that not all of that dose is going to make it down into the patient's lungs, and some of it will not just be deposited in the ET tube, but also in some of the circuit itself. So often the actual dose will not be 3 puffs, it may be 6 puffs, and then following an assessment in 10 or 15 minutes, and perhaps another 3 to 6 puffs if the normal dose was 3. So again, a little bit more on the aerosol administration in mechanically ventilated patients. So the technique used for assessing response to the bronchodilator. So the techniques that are used in ventilated patients are very similar to ones who are not on mechanical ventilators. So these techniques, measuring change, the difference between peak and plateau pressures. If you recall, your peak pressure is a determinant of total impedance. Total impedance is a combination of compliance and resistance. However, the difference between peak and plateau strictly relates to resistance. In point of fact, the difference between peak and plateau pressure, if you will, divided by the flow in liters per second, will actually give you the resistance. So a drop in peak pressure during mechanical ventilation, with all else constant, so you haven't changed the tidal volume, etc., suggests that there's been some positive effect from bronchodilators. Automatic positive and expiratory pressure levels may decrease in response to bronchodilators. And again, one of the things that you look at is that may be driven by autopeep. So one of the actual causes of autopeep is bronchoconstrictions, resistance. And there's obviously a lot of ways we can manipulate E time in order to achieve less autopeep or intrinsic peep. But if the cause is indeed bronchospasm, that's one way as well. And again, breath-to-breath variations, just looking at your patient, looking at your parameters, giving the medication obviously some time to actually work, so it may not be immediate. You've given let's say the 6 puffs of albuterol, or you've used a vibrating mesh to give 2.5 milligrams of albuterol normal saline. So these drugs take 10 minutes to start to work, and they don't peak for going on an hour or something along those lines. So you look at breath to breath, but you got to give it time for these medications to actually work. So this image is just a little more clarity for you visual learners such as myself, really showing you this happens to be a 980 mechanical ventilator, and it actually will show you where that vibrating mesh. I have a circle there which is showing you the vibrating mesh, and also the controller cable there. But you're seeing its placement is again in between the humidifier and the ventilator outlet, obviously in the inspiratory limb. So now I want to speak a little bit about the controlling environmental contamination. So really what we're talking about is not so much, if the nebulizer drops on the floor, throw it in the garbage can, get a new one. But we're not really talking about it. We're talking about exposing folks such as ourselves, This is not just a COVID-19 issue. It's always been an issue, but obviously COVID-19 really brought certain things to light, or brought them placed greater emphasis on certain facets, including, again, minimizing cross-contamination. So exposures, so nebulized drugs may enter the room directly from the nebulizer or during patient exhalation. Continuous pneumatic nebulizers produce the greatest amount of secondhand aerosol. So controlling these exposures using one-way valves and filters can help. So one of the actual models that are out there, and I'm not particularly endorsing this one, I've actually worked with the circular small volume nebulizer, and I'll show you an image of it shortly, that actually does contain a collection reservoir. It does contain a filter and a one-way valve in order to try to minimize the environmental exposure. And some hospitals use either this or other similar nebulizers in order to minimize the cross-contamination. Negative pressure rooms is a bit extreme, but think about it, and treatment booths are also useful strategies. So, many hospitals have negative pressure rooms, but there were a lot of rooms that were converted into negative pressure rooms during when I say during COVID continues, but thankfully the prevalence and the severity of it have dropped dramatically. Personal protective equipment is recommended when caring for a patient with disease or suspected to have disease, and which can be spread by the airborne route. This is an image of the circular small volume nebulizer. Here again, I've added some, if you will, circles to just point out some key points. So this particular one has a mouthpiece, as you can see, all the way on the right-hand side there. But circular also come with a mask. You can give it with an aerosol mask. But if you really think about it, if you want something closer to a closed system, a mouthpiece will better achieve that than a mask. You also see the circle on the right-hand side there. There's one expiratory filter that's located there as well. And then, you actually have a one-way valve, which is that middle circle. And then all the way on the right-hand side, the largest circle is a collection reservoir. So it sounds a little crazy. The patient's actually rebreathing, but they're rebreathing some of the actual medication. And as the small volume nebulizer, which is the lower portion of this setup with the purple top there, as the small volume nebulizer is actually, you think about it, you're running it at 7 liters a minute, which is what circular, the company manufacturer, calls for. You're running this at 7 liters per minute. In between breaths, you're washing out some of that CO2, because whether you're using air or oxygen to drive the nebulizer, again, some of that is also going in the reservoir and, replenishing the oxygen and washing out the CO2. Let's talk a little bit about biologic therapy. And I have a confession. And the confession goes like this, that this is an area that I too am learning about as we speak. There's a medication, and I'll talk a little more about it in a few moments, called Xolair with an X. So Xolair has been actually out for about a decade or so, but it wasn't really heavily used. It wasn't heavily known about. And it was really one of the first that was not just approved, but it was really popularized. Now there's a real host of other of these biologics that, and I'll talk a little bit about the way that they work. But for some patients who have been tested and they're shown to basically have certain types of antibodies that are contributing to the worsening of their asthma, or they have eosinophilic asthma. So there's obviously supplemental testing. It's not just pulmonary function testing. It's supplemental testing that needs to identify that that's the cause, or that concurrent with an asthmatic episode, that certain biological markers are in fact increased. So in the presence of that, when these patients are started on these medications, and again, it's not an immediate, it's not like taking a adrenergic bronchodilator. It's not immediate, or doesn't occur in the first day or so, or first few hours. They can be very effective. They can be life-changing for some, and in some cases, many asthmatic patients. They target specific mediators implicated in airway inflammation. Currently, there are agents that target, and again, I'm not going to read this slide to you, but anti-IgE, anti-IL-5, and others that really are implicated in contributing to the inflammatory cascade that impacts, that causes bronchoconstriction, tightness, wheezing, difficulty breathing, etc. The choice of the specific biologic is heavily, based on the suspected phenotype, the suspected underlying cause, okay? And again, if it's, IgE levels or eosinophils, there's certain biologics that the patient would be started on in order to target that versus, if it's IL-5, there's others that they could be started on. So there's a lot going on in this slide. And what am I going to say? A lot of colors, some arrows, this point and that way, et cetera, et cetera. The point of the slide isn't, I'm not going to, it's not an algorithm. The point of the slide is this. It's listing, okay, it's listing that, different sorts of biologics that are on the market. Rengen 3500, and others. Notice that most of these end in MAB, okay, in MAB. So you have three, if you want, purple or ruby colored rectangles on the left-hand side, and then you have 5 on the right-hand side, different spots that are blue. Those are all the latest, if you will, monoclonal antibodies or biologics that are actually, have been used. And so it's giving you the names, but it's also pointing to the notion that, they're operating on different elements of the inflammatory cascade and different mediators. That's really the point of the slide. Different biologics have different specific targets in the inflammatory cascade. So a little bit on Xolair. Okay, Xolair, again, was one of the first that was actually introduced. And again, it's approved currently. So, I'm not going to read this slide to you, but it's actually approved for individuals 6 years old or greater. But those that have a specific IgE level, okay, 30 to 700 international units per milliliter, positive allergen testing, and incomplete control of moderate to severe asthma. So they're still relying heavily on their beta-adrenergic. They're missing days from school and or work. The way they're administered, and again, self-administered. Obviously, if it's a 7 or 8 or 9-year-old child, probably it's not self, but mom, dad, guardian, or doing it with the child. But for older individuals, they actually take an injection subcutaneously every 2 to 4 weeks. Decrease the rate of asthma exacerbations by 25%, may cause sustained improvements in some of, FEV1, but some other measures as well. And then there's some other improvements that have been seen. Again, this drug this is not brandy new, but it's become being regarded as something that's pretty tried and true in certain specific patient populations. Nucala is yet another one, and it's really anti-IL-5, and IL-5 is just another one of those mediators that's implicated in, it's actually part of your immune system, but allergic asthma is really, a lot of that is about your body recognizing, a certain, a stimulus or stimuli, more than one, and responding to it, thinking it's an invader, revving up the immune system, including the antibodies and these substances, and ultimately trying to ward it off, but also in the process of trying to ward it off, creating inflammation, swelling, excessive mucus, etc. So this is also for over 6-year-olds with severe asthma, and this is really one that's focusing more on the eosinophilia, and again looking at some particular thresholds that exist for the once the testing is done to determine if a patient is a candidate or not. They're looking for certain thresholds. And again, they're looking at 150 microliters, preferably greater than 300. So minimally 150. But 300 or more would really be saying that this patient may be a candidate for Nucala. And again, it may also also improve rhinosinusitis, nasal polyps, and just different. Think about this. Someone has a drippy nose, a runny nose, they have sinusitis. A lot of that, the etiology is the same. It's the body kind of reacting. It may be a cold, but again, if it's for a sustained period of time, it's weeks and weeks and perhaps months and months, or it's a steady state, it's not a cold. It's something beyond that. This particular one is taken sub-Q, 400 milligrams every 4 weeks, again, self-administered and or observed. And with this one, again, in the target population, it's a significant reduction in exacerbations, 50 to 60%. Improved quality of life, steroid reduction usage. So there's a whole lot of benefits that have been associated with Nucala as well. And by the way, some of these medications you've probably seen advertised on TV. A lot of you are respiratory therapists, maybe a few of you are nurses. Depending upon what setting you work in, you probably encounter patients that are on some of these biologics, or as much ones that should be. So just kind of an interesting, interesting trend that's actually happening as we speak. Yeah, so I'm not going to spend a lot of time on the rest of these, but there's another example here. Sinquare is another one, anti-IL-5. But note, this one is for those that are 18 years, over 18 years old. And again, with severe asthma. And, the administration over 20 to 50 minutes every 4 weeks. So this one's more of a, a slower, IV type of, type of administration. Decrease exacerbations dramatically in this particular patient population, but the studies are kind of newer. This is one of the newer one, and in fact, for all of these slides, I've included, some references on the bottom there that really talk about some of the research that's been done. So in this particular case, limited data showing a reduction in the use of steroid, inhaled steroids, et cetera, et cetera. So again, we're not quite, the ones that the biologics that have been more recently introduced. There's less known about them. We know that they're pretty safe, but their efficacy is still being investigated, and particularly identifying which pockets of patients are more likely to benefit from these medications than others. Fasenra is yet another, again, anti-IL-5 receptors, or what's really targeted here. This particular one for over 12-year-old with severe asthma and other particular inclusion criteria. This one is a sub-Q, basically every 4 weeks, 3 doses, and then spreading it out every 8 weeks. Also shown to reduce exacerbations, reducing steroid administration by as much as 3/4, by 75%. Dupixent is another formulary that's out there, approved for moderate to severe, asthma in individuals that are greater than 6 years old, but they're also ones that are found to have eosinophil levels that are greater than a certain threshold. In this case, 150. Because these medications squelch the inflammatory cascade, some of these medications, including this one, has also been found to be somewhat effective with eczema, with chronic rhinosinusitis, nasal, polypsis, and other inflammatory, diseases and conditions that are out there. And a little bit more discussion in the subsequent bullets there on, decreasing the exacerbations by 67%, decreasing steroid use, increasing, pulmonary function testing, FEV1s, and other findings of flow in, again, PFT testing. Still another example is listed here, newly approved. Again, this one looks like it may be more applicable in a more of a general population, okay? So Trespire is what it's known as. Severe asthma in those that are 12 years old or older, sub-Q every 4 weeks. And again, significant improvements in PFTs with a reduction in exacerbations. The big deal with this one is it looks like it's less specific to a particular causative agent, and it's further down the inflammatory cascade where it may actually benefit those with different types of mediators that are implicated. And this is a slide just looks at some of these medications kind of collectively, if you will, and it gives you, a little bit, kind of a summary slide, gives you a little bit on the molecular, the mechanism of action, and the effects that have been shown in certain research trials. So again, a little bit of a comparative look here for those of you who just, don't want to look at these singularly and say, who might benefit from this, and what sort of findings have actually been determined. So I just want to wind this presentation up with a few take-home points. The first of which is asthma still accounts for a significant amount of morbidity for patients and loss of productivity. We've come a long way, however. However, again, much greater emphasis on education, on patient and family education, and on management and prevention. However, there's still a lot more work to be done, and it's just interesting to stay abreast of these developments. Knowledge is empowerment, which better enables us to to advocate for our patients, perhaps advocate for family members, advocate for our profession, etc. So stay tuned. As I said to you earlier, I learned a lot in preparing this presentation, not just on biologics, but reinforcing other information that maybe I kind of was solid on at one time, but maybe less solid now. And I hope that you guys got something out of this as well. So lastly, here's selected references. Again, we have some particular manuscripts that talk to some of these developments. Also included Egan's Fundamentals of Respiratory Care, which covers a lot on pharmacology, the administration of these medications as well. So again, thank you for joining us. I'm really hoping that you got something out of this presentation. I hope you enjoyed it as much as I did, actually, not just preparing it, but presenting it. And I really hope that you guys come back to A&T Lectures for your for all your continuing education needs in the realm of respiratory care. Thanks a lot for joining us today, and have a great day.